Hey guys, Woodruff here. So we are, I'm gonna say ankle deep. I don't know how deep we are in diabetes. And so we are getting into maybe part five-ish. I want to say for diabetes. Now we're into chronic complications. So we just got done with acute complications. And now we're getting into chronic. So there are and then also the preface. So far, been lucky, haven't been interrupted by the crazy child. I'm recording these during the Texas snowstorm of February 2023. So, if you hear any screaming or loud noises, everything's fine. Anyway, so chronic complications of diabetes. This is going to be more long-term stuff that can happen. And these are the things I talked about that a patient with like type 2 diabetes can come to the hospital with these first before we even know they have diabetes. So in other words, this is all the stuff that how the damage to the blood vessels can lead to serious problems. And we again talk about where are our blood vessels? They're everywhere. So this is how systemically or the whole body is affected by having too much sugar in the bloodstream over time. And so we're going to look into each of these. These are just all the ones we're going to talk about. So first, let's talk about diabetic eye problems. This is what is known as diabetic retinopathy. Is probably one of the most common ones you're going to hear about or see on a test question. This is effectively what's happening is that because of irritation from glucose, there's these little hemorrhages or bleeding that end up what do you call it causing inflammation, and there can be effectively the inflammation and bleeding and these little hemorrhages that can happen in the blood vessels of the eye lead to decreased vision. It can actually lead to complete blindness, and so it's usually a combination of there's too much sugar and there's too much pressure in the blood vessels, and this is usually a result of having issues like where there's cardiovascular problems and then also diabetic problems. Other things that might happen aside from retinopathy can also be glaucoma and cataracts, which sadly we have to learn about later in the semester. So you don't need to know too much about those, but just know you can have a lot of eye problems, and people with diabetes are more likely to have eye problems. But so you should be thinking as the nurse, what does this mean? This means that I need to be checking their vision and looking at stuff more closely. But I'm just throwing that in there. Treatment for diabetic retinopathy, you don't have to know deep about the surgeries and other things, but there are surgical procedures. We can put steroids, implants to decrease some of the inflammation that's happening in that area. But the main thing is prevention. So if we maintain euglycemia or keep a more steady blood glucose, and if we treat their blood pressure with antihypertensives and keep it in a solid range per their doctor, um, then we can definitely decrease their risk for having this. In other words, this doesn't happen to everyone who's diabetic. It happens, it's usually a sign of poorly managed blood pressure and poorly managed diabetes. So we usually these things are going to get a lot or significantly worse with high blood glucose. So that's really what we're going to manage. And you're going to kind of see that as a pattern. All of these things, it's like manage your blood glucose. So that's why that's going to be a key point for our treatment as a nurse. So there's also what's called diabetic nephropathy. Now keep a close eye on this because there's nephropathy and there's neuropathy. Nephro, Nephro. So look at that, read really carefully, because on a nursing school exam, I've seen students get things wrong because they read it wrong, because your brain reads it quickly. And if you have nephropathy on the mind, you're going to think nephropathy. If you have neuropathy on the mind, you may see that even though it says nephropathy. So always be careful. But nephro is talking about the kidneys. So the kidneys are also a very vascular place. And like this picture showing, if you have all this sugar around this very vascular organ, it can lead to irritation, breakdown, inflammation of the blood vessels of the kidneys, and then they can't work. I think of the kidneys as a big fishing net. And so if the big fishing net starts to get irritated, some of those, like those holes that particles are supposed to go into, can get wider, and things that are not supposed to get out, get out. And that's why, one of the tests that we use to see how their kidneys are doing is what's called albuminuria, and it's looking for albumin, which is a protein in the urine. Now, usually we do not lose albumin in our urine because of that fishing net in our kidneys is not wide enough to allow albumin to slip out. But if I'm starting to have irritation, breakdown, inflammation, that fishing net, or think of it like a filter, because it is a filter, is not supposed to let out those proteins. But if it's starting to let them out, it's a sign that there's a problem with that filter, which can usually commonly be linked back to poor diabetes control and high blood sugar. This is also the leading cause of end-stage renal disease in United States. So a lot of times, like if you ever work on a nephrology unit, you are going to see diabetes, and a side of diabetes, because diabetes and kidney disease, diabetes and heart disease are so closely linked. So again, they get yearly function tests and screenings for the protein in their urine helps to tell that they're starting to have a problems. They're not filtering as well. Their kidneys are starting to lose their function. And then in the meantime, we can again manage their blood pressure because blood pressure, the kidneys are all about flow. And so if my blood vessels are super clamped down and I have high blood pressure, there's not going to be as much flow. Think of it like a hose. If you clamp down or bend or kink a hose, it's not going to allow flow to the kidney. So it's the same thing. If my blood pressure is really high, it's not going to allow for enough flow. And then also keeping the blood sugar under control. The less sugar that's going to be there irritating the blood vessels, the better off that I'll be. Specifically, the medication that we like to use um, with diabetic nephropathy is what are called ACE inhibitors. So we'll learn about these when we get to cardiac. And the odd thing or the funny thing you're going to find is that they actually can cause harm or damage to the kidneys, but specifically for diabetic patients, they have a kidney protective effect. So we use them in patients that are at risk or showing signs of diabetic nephropathy, and these can help to slow that process down so that they're not going to go into the state of nephropathy as quickly, or they're not going to get as severe in their kidney damage as quickly. So it does have a protective effect to the kidneys. So, and all the ACE inhibitors, they end in prils, like PRIL, or the sartans. So, like losartan. So there's also diabetic neuropathy. So most people see neuropathy and they think it's something with the brain, but diabetic neuropathy is talking about nerves. So think diabetic nerve problems. And so this is a problem where patients have either a loss of sensation. Sometimes they can also have like change in sensation where they have hyper sensation, but they can complain where they have pain. They can complain of decreased sensation, like numbness of their extremities. They can complain of tingling, almost like it's kind of like their limb is falling asleep. So this is this is probably the most common complication you're going to see. So this is why when I assess my diabetic patients, is that I always ask them if they have any neuropathy before I touch their feet, because a lot of times you touch their feet, they are screaming. Their feet can feel like they're on fire. So they can have extreme sensitivity to pain, pressure, touch. So before I even take those covers off, I always ask them like, hey, do you have any numbness or tingling? Because that can tell me so I can best help to prevent them from hurting them while I'm doing their assessment. So the biggest things here, and what's happening here is effectively, it's all about the nerve endings is that glucose gets down, starts messing with the nerves near the blood, and also the blood vessels are not supplying the nerves anymore. So that can be the loss of sensation, but either the nerves are irritated or they're not getting blood flow. And as a result, sensation is altered. So I'm going to maintain good blood glucose. Again, it's going to be my key thing because less sugar in the blood, less irritation or less loss of blood flow to my nerves. Pain management is key. You do not have to know all the names, but some of the medications that we give is like gabapentin or Neurontin, Lyrica. A lot of these, it's either like antidepressant meds that can work on nerve pain, or gabapentin or Neurontin is an anti-seizure, and these all work by effectively tricking your brain that it stops pain signals from sending. It can help to alleviate some of those odd sensations, but pain management is key because pain can be really hard for these patients with this neuropathy. We want to prevent injury because if they have a loss of sensation or a loss of feeling, think of it like when you cross your legs for too long, or if you, sit on, one of your limbs for too long, it can start to get numb and tangly because it's less flow to that area. Is that these people may have injuries to their extremities and not even know it. We'll talk about that more in the next slide. But we want to prevent injuries for these patients. And then also good skin assessments and foot care are going to be key for these patients. Because pretty much I have to be their eyes because they can't feel it. And if they can't see their feet, etc., you have to think about how some of these patients look. Some of them may be obese, some of them may not be able to bend over or even see what's going on with their extremities at the time. So anyway, So, feet and extremity complications, kind of continuing to go, is that because of the decreased sensation, that's one of the parts of it. Also, because these people are more likely to have more plaque issues because of their cardiovascular disease risk. Remember, I say in an earlier video, they can have issues with plaques as a result of insulin resistant issues and too much sugar. It affects how much cholesterol and stuff that you are collecting. But what's happening here is that as a result of not being able to feel or being able to know when there's an injury, and also having poor blood flow issues because of too much sugar and because of blood vessel issues, like people, again, also commonly have cardiovascular, including some vascular problems like what's called PAD. And this is where there's plaque buildup in my arteries, especially in my legs, which can lead to decreased flow to my extremities. Is that these patients are very high risk for feet and extremity complications. A lot of them end up with ulcers and amputations at some point. And part of it is that loss of sensation. It's called LOPS, LOPS, loss of protective sensation. It's, in other words, like the fact that I feel pain is a protective mechanism in my body that's telling me, hey, there's something wrong here, investigate. So when I lose that, then I'm unable to know. So, I mean, this can happen obviously in people with diabetes, but I even had a patient the other day that, did so much heroin that she didn't even notice that her feet got frostbite. And so this is the thing that can happen is when you lose that protective sensation or lose that ability to know when there's something going on, that you need to intervene. You can end up no blood flow. No blood flow means infection sets in, which means I can lose that limb. So like for the patient I had, again, they're not diabetic. This was a different issue, but similar thing is they lost all the toes on one foot and they had to get a below the knee amputation on their other leg. So this is something very similar that can happen for a diabetic patient. A lot of times we're slowly, like we start the toes, we take their toes, then we take a little bit of their foot, then we take all of their foot, then we take their below the knee, and we slowly have to start moving up because this is what happens when they start having less flow. This is why it's so important to keep a steady, good blood sugar and meticulous foot care. And we're going to talk about foot care in an upcoming slide. And then, like I mentioned, the other thing is they can have what's called peripheral artery disease. And we'll talk about this when we get to cardiac soon. Yay. Needless to say, what's happening here is there's a whole bunch of plaques building up, and then there's also a narrowing of the arteries in the legs, which leads to decreased flow, on top of the fact that I already maybe can't feel, have diminished flow, nerve issues in my legs with my diabetes. So for this, again, managing blood pressure, and there is surgeries and other things that can be done, managing cholesterol, all of those things are going to help there. Oh, teaching corner. So, a nurse is providing education to a client with diabetes and regarding foot care. Which statement by the client would indicate teaching was effective? So, anytime you have a question like this, you want to see, is it asking for what's right or what's wrong? And for this one, it's looking to see how teaching was effective. In other words, it's looking for what's right. And so let's find which of these is right. So the A says, I will only go barefoot on soft ground like carpet. Well, I mean, that sounds pretty good, but I think that they're not supposed to go barefoot ever, like on nothing. Like soft ground sounds nice, but I don't think they're ever supposed to go barefoot. So I'm going to say no for that one. It says I should avoid using any creams or lotions on my skin. So I feel like they can have issues with dry skin if they're getting less blood flow to their feet. They might not be able to, be getting as good of moisture. We might need to moisturize, but I do feel like there's something we want to avoid. Like maybe we don't want to put lotion or creams or moisturizers between the toes because it could lead to like fungal infections. Um, but I don't think that this whole statement is true. And remember, with something like this, if it's looking for what's effective, if there was two parts to the statements, they both have to be true. Make sure the whole statement is true. Ever report wounds that have not started to heal within 24 hours. Well, that definitely sounds like it would be helpful because if their wound isn't healing within 24 hours, it may need additional treatment, antibiotics, might need to investigate, make sure that there's not dead tissue or, something serious going on, like some gangrene. So that's the one I like the most so far. And then D is I can use ice packs to my feet when I'm experiencing neuropathy. So I know that they do have pain, but I don't think ice would help. Ice is a vasoconstrictor, and that's going to even decrease my blood flow even more. And then they can't really feel exactly the same way. So they can end up having an injury from that extreme cold temperature. So I think the only one of these that sounds reasonable and that it won't cause harm is going to be C, that they're going to report their wounds that have not started to heal within 24 hours. So there's a lot of teaching around foot care for diabetic patients. Here's some of the highlights. We want them to examine their feet every day. And the one thing to keep in mind is a lot of people that have diabetes complications, it's not like you just get one. You could have all of these complications we've mentioned so far. So if these people have visual loss or visual problems, we don't want them examining their own feet. So if they have good vision, great. But if they have retinopathy, they should not be examining their own feet. Someone else should be looking for them because we cannot trust their vision. We want them to wear comfortable, well-fitted shoes. So we don't want them to be too tight, but we definitely don't want them to be too loose. So we want them to make sure that they're wearing the appropriate shoes. We want to avoid, this is why that one answer was incorrect. We want them to avoid very hot or very cold things on their feet. They're not going to be able to tell when it's too much. So like, for example, like putting a heat pack on their foot, they could get a burn because they can't feel adequately that that is too hot. We do not want them to ever go barefoot, no matter how soft and everything the material is. They just are so likely. A little cut for them can make like a huge difference and can lead to massive infection. We want to apply moisturizers to the surfaces of the feet, but not in between the toes, again, because it can lead to fungal infections. Between the toes is just such a place where moisture can build up and lead to growth of bacteria and other funguses and things like that. So nothing in between the toes, but on the surfaces, absolutely. Clip the clip the nails carefully. And this is where we usually say like cut straight across. We don't cut down on the edges. A lot of diabetic patients go and see a podiatrist, and the podiatrist clips their nails to make sure that they're done correctly so that they don't have injury. They need to be super careful because they can easily clip their skin when clipping their nails and lead to a major injury, which could lead to loss of limb. Because everything goes down to like if they get an infection or a wound down there, oxygen can't get there because there's not good blood flow. There's all that sugar which is irritating the nerves, and so they can't have the proper immune defense to actually get to where it needs to go. And so a lot of times these patients end up, they don't heal from infections. Well, they don't have the immune, like their immune defense is weaker, and then they don't have the actual route to get the immune defense that is available even to that site because of the poor blood flow. So we really have to be careful with infection in these patients, especially in their extremities. Avoid prolonged sitting, standing, or crossing of legs. So nothing that's going to impair or decrease circulation. So if I'm sitting for a long period of time, standing or crossing my legs, it leads to decreased blood flow to certain areas. We want to clean their feet with a mild soap and then dry it well. We don't want anything very caustic, which goes into that. We don't want to ever put iodine, rubbing alcohol, or strong adhesives on the feet. All of these things can lead to breakdown of the skin, irritation, and especially like if I get a cut or a wound, I want to use something very mild to clean it and to to help to cover it. And then, like we talked about, if they do not see improvement in their symptoms or start to see some healing within 24 hours, they should definitely go see a doctor and report that. No open-toed or high-heeled shoes, as those can lead to, open areas for infection to happen or easy for stuff to rub or cause harm to their feet. And then cotton and wool socks are best in order to, prevent any sort of injury or breakdown of the skin. Mhm. All right, so there's also problems with emptying for diabetics. So one of the problems that you're going to hear about is what's called diabetic gastroparesis. And this is also known as diabetic autonomic neuropathy. So it's a part of, I think autonomic is automatic systems. So these are the systems that normally, like both in, we're going to talk about, there's problems with your stomach, and then there's also problems with your bladder. These both, they operate, there's sphincters for both of these, and they operate that they get a signal that says, hey, it's time to empty. And some of them are pressure dependent, like when the stomach gets so full, hey, it's time to empty. When the bladder gets so full, hey, it's time to empty. But what happens in diabetes, again, because of the lack of blood flow and the decreased irritation in the blood vessels, what happens is that they have less less of that sphincter being able to open, or the sphincter's not getting the message to open. So these people end up getting full. So think of the problems with emptying is that both with the stomach and with the bladder, they can get full and not empty when they're supposed to. So what happens, it's not that they never empty, but they just empty, it's delayed, which can lead to serious problems. So with gastroparesis, think gastroparalysis or stomach paralysis. So there's less of an emptying going on in the stomach. And this what happens, patients may complain, "Hey, I'm full," more often, or they may have nausea, vomiting because they're so full. But the big issue here, and people don't understand this, is that your stomach is not a place where you absorb nutrients. You absorb nutrients in your intestines. So if all of my nutrients are staying in my stomach, all that sugar that I need, I just took insulin, I took some other, medication for my diabetes. If they're not getting absorbed, if I'm not absorbing nutrients or sugar in order to help combat that medicine I just took, and even if I don't take medicine, even just alone, if I'm not eating or the nutrients aren't getting absorbed because they're all staying in my stomach, I'm very high risk for hypoglycemia. So a lot of people might say hyperglycemia because you have all this food in your stomach, but you're not absorbing it in your stomach. It's just chilling there. Um, and then, what do you call it? Usually we treat this with medications that are going to help increase our gastric emptying or motility or get things moving forward. I was like, I need to take a break because I'm getting rather dry on this, whatever part 5 or 6 that I'm on. So then there's also the neurogenic bladder. And what can happen here is if my bladder is full and it's not getting that message or signal to release the urine, I can get urinary retention. This can lead to infection. This can lead to bladder rupture, which are two very serious things. So I'm going to have to do interventions to help to encourage them to have better urination. There are some medicines we can use to help with emptying, but usually what we start with is least invasive first. So we start with things like timed voiding, which means like, hey, every so many hours, you're going to go sit on the toilet, even if you don't feel like you have to go. And sometimes that mechanism can help to promote you to go. There's also what's known as Craig's maneuver, which is where you take your hands and you push down literally above your bladder, and that pressure can force open that the sphincter and force you, kind of like if you press on people's bladder, sometimes some pee comes out, they can't help it if their bladder is full. It's a similar concept where you're literally putting pressure on the bladder to encourage that sphincter to open. And then last but not least, self-catheterization. If all else fails and we just cannot get that sphincter to open, we will have to cath them either temporarily or permanently. But again, least invasive first. So I always want to start with the least invasive options. Other problems, they can have what's called cardiovascular neuropathy, like postural hypertension, which is like orthostatic hypotension. So they may get lightheaded, dizzy when they're changing positions. They can have what's called resting tachycardia, or like their heart rate is just more elevated just at rest. And probably the scariest one is that they can have what's called a painless myocardial infarction. In other words, they can have a heart attack, but not feel it at all. So this kind of is like neuropathy, but for the vessels in the heart. So normally my heart tells me, ouch, I'm not getting oxygen. Help me, get me some oxygen. You feel like crushing chest pain or a lot of symptoms that are saying, hey, do something. But because of the lack of blood flow to the nerves around my heart, if those nerves can't send signals and tell my body or tell my mind, hey, my chest is hurting, then we can have what's called a painless MI, which could obviously lead to very serious death and damage. So well, you'll learn about this in complex, but people that are diabetic may have no symptoms for a heart attack or may have atypical symptoms. So we definitely need to look for those alternative symptoms sometimes for those patients. Also, there can be erectile dysfunction or decreased libido because of there's a lot of nerves there. So, doing general counseling and erectile dysfunction meds can help with those. Now, that might seem very minor compared to I just talked about a painless heart attack, but know that these things can have a serious effect on quality of life. And so we want to definitely consider all parts of the body that can be affected. So there's also what's known as hypoglycemic unawareness. So this is something that we talked about earlier when we talked about what do you call it? Hypoglycemia, that there's some people that literally cannot tell that their blood sugar is low. This is a possible emergency situation. People that are going to be more at risk are those that have had multiple episodes of hypoglycemia because their body maybe eventually gets to the point where it's like, hey, I'm not even telling that I have hypoglycemia. It can be in older patients who may not have the same sensory functions and things like that, or be able to tell the same signals, or some of their body systems are getting older, maybe not functioning the same. They may not have that, fight or flight reaction that comes through. And then we already talked about with beta blockers. Remember, beta blockers block sympathetic nervous system. And if one of the ways my body tells me I'm hypoglycemic is by a sympathetic nervous system activation, that tachycardia, that sweaty anxiousness, then there's no if I'm blocking that reaction, then I'm not going to be able to tell that the patient is hypoglycemic. So with these patients, what we normally have to do, if they can't tell, because there's sometimes they're out there driving their cars, doing other things, their blood sugar is 20 or 30. Super dangerous. They can pass out. They can cause major accidents. A lot of times that's how they present. They come in with a car accident. They didn't even know they had a low blood glucose. So what we usually do with these patients is we usually like to keep blood sugar pretty well managed. We don't want them to have a lot of high blood sugar, because we've been talking about this whole time. Every other one, we're like, keep their blood sugar stable, like make sure their blood sugar is not too high. I know I didn't mention it for like the gastroparesis and urinary retention, but it's kind of a given. For all these complications, we usually want to keep their blood sugar well maintained. But for these patients, it's super dangerous to keep if they're too close to low. So a lot of times we want to maintain them a little higher, maybe not give them as many meds, because we do not want them to hit those lows, because they're not going to know when they hit those lows. Other complications, like I've already mentioned, with infection, they have impaired immune defenses. In other words, like their immune system just does not have as much umph or drive in order to help them. So because they have less of an immune defense, they already have less guys to come help. But then on top of that, we have less blood flow to all these areas where infection is happening. So it's a lot of hard, even with the guys that we do have, to get them there, because we don't have good flow because of all the sugar in the blood. These people are commonly have recurrent yeast infections because they're losing glucose in their urine, or they're common to get UTIs. So we need to make sure as a whole, as the nurse, to get early treatments to prevent any sort of serious complications. We want to keep things clean and dry, do proper perineal care, make sure we're washing our hands, or teaching them to wash their hands, knowing how to wipe front to back, how to prevent these kind of infections, especially for women, again, who are more at risk for the UTIs and the, what do you call it, whatever you call it, blah, 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 yeast infections. There we go. But on top of that, just know that a lot of times where other people might be able to be okay and fight the infection on their own, a lot of these patients are going to need antibiotics more often than not. And they may also have they're also going to be very high risk, in the high risk category, for needing to get vaccines first. So like when we talk about people that are immunocompromised or really at risk for infection, this is diabetics. So they're going to be top of the list to get vaccinations, and in that high risk category where they need them sometimes more than others, because they have such limited immune defenses, and they are really unable to get the guys that they do have to the infection to fight. So they are going to need to keep up with their vaccinations. And then psychological complication, there are high rates of anxiety, depression, eating disorders, things like that. So just making sure to connect them with psychological support, 12-step groups as needed, therapeutic communication for these patients, knowing that like a lot of times it's really hard. I've taken care of a lot of DKA patients, and sometimes they come in and they're like young, 21 or less. Oh, here's my first interruption. Yes, sir. Hold on a sec. Let me pause this.
Tell me to go potty.
Oh, okay. We'll go potty then. Story of my life. Okay, good for you. All right. All right, go ahead. So if you hear someone pottying in the background, it's not me. Anyway, and so sometimes you take care of these really young patients that they have a lot of issues with like they're not really taking care of themselves, and you're looking at them like, you're like, this patient is so young, they should be able to take care of themselves. Like, what's wrong with them? Why aren't they taking care of themselves? But just know, like, a lot of times these people, especially type 1 diabetics, they're sick from a young age. They're in and out of the hospital every few weeks or every few months. There's infections, constant complications. It's exhausting, and it gets to the point where it's just really hard. That will to live, that will to keep pushing and to take care of themselves can get really low, and not everyone has the same resources that other people have, or the same support. So try to work on your own opinions and judgments you might have around these people, and make sure that you are providing the therapeutic communication. And a lot of them may end up on medications for depression and anxiety. So, in general, as a whole, we want to, as the nurse, do a thorough head to toe assessment, especially with the skin, looking under everything, looking for any skin complications or issues. We want very good medication compliance because, like I said, everything's about managing that blood glucose. They need to be taking their medicines regularly. You could see in a lot of these, there was a very close link between cardiovascular or vascular health and diabetes. So we want to always make sure, don't mind my son in the background, um, and he's gone. So yes. All right. Anyway, we want to make sure that we are maintaining their cardiovascular health and because that's going to help prevent other complications, like I talked about, managing their blood pressure, their cholesterol. Regular health screenings and health maintenance or care, because even if we can't necessarily stop some of these complications from happening, at least if we can tell that they're happening early, we can get the help that they need to help treat this patient. Infection prevention or aseptic technique is going to be key. General weight loss and dietary changes. Now, it's going to depend on the patient. Not everyone needs weight loss, but if that's appropriate for the patient, absolutely. And then lifestyle changes, exercise, healthy diabetic diets. We also do heart healthy and diabetic diet. We'll talk about that. And then quitting smoking, because if we already have a blood vessel issue where we already have all this sugar in our blood, it's going to make it that much worse because the byproducts or the chemicals in cigarettes also do incredible damage to blood vessels. So if I already got this irritated blood vessels from sugar, I do not need to add in other stuff as well. Okay. So this is a great time. I'm not going to necessarily do this, but this is a great time to take a pause and think about the education that a patient needs from head to toe. So starting at the top and thinking about, okay, what can happen with the head, the eyes, the nose, the mouth, and like go through each organ, each body system, or at least each body system, doesn't have to be every organ, and just go from head to toe and think about everything that you would teach a patient from head to toe, how to prevent chronic complications. This is a great way because there's so many complications. But if you start like, okay, here's the eyes, diabetic retinopathy, and you go down the lungs, they could get a lung infection, their heart, painless MI. You got your stomach, gastroparesis. We got the bladder, it's what's called a neurogenic bladder, or with the urinary retention. Then I've got the legs, peripheral artery disease, the feet. We have the neuropathies and stuff, and I know I missed some, but that's just kind of a good place to start. Is kind of thinking of it head to toe. It might help you visualize it better. I think that's where I want to stop. All right. So we have gotten through all the complications now. So next we're going to move on to the next section is going to be all about medication and other management. We are, I would say, about halfway through the diabetes lecture. Hopefully you're still surviving, and I bet you're glad I'm breaking it up into small parts so that you can take breaks in between and still survive. Anyway, I'll see you for the next one.